So first we're going to start up here for the landmark of the greater trochanter of her femur, and that is where the stationary part of the goniometer will go. And I'm going to palpate superiorly to the femur to find the lateral epicondyle of the femur, which is right here. And then I'll continue down the midline of her tibia towards her fibula, and I will palpate the lateral malleolus of the fibula. The stationary part of the goniometer will stay in alignment with her greater trochanter, and the fulcrum will go right where the lateral epicondyle is, and the moving arm will be in alignment with her lateral malleolus. Now I'm going to have you lift your foot as far back as you possibly can. I'm going to push it a little bit to see if we can get any more flexion. And the goniometer reads 127, which is normal. It's usually between 120 and 150. Now we'll move your foot down again, and I'm going to place this towel underneath your ankle to avoid any hyperextension of the knee. And we'll do the same thing. Greater trochanter of the femur, the stationary arm, fulcrum will still lie at the lateral epicondyle of the femur, and the moving arm will still be in alignment with your lateral malleolus. Now, at normal extension, I'm going to push down a little bit just to see if we can get any more extension from you. And you are at 0 degrees of knee extension. So we'll be testing muscle manual testing for knee extension and knee flexion. And now I'm just going to test the range of motion to make sure it's good. So first I'm going to rotate her foot medially so we can palpate both the semitendinosus and semimembranosus. And I'm going to stabilize her pelvis while she does that. Can you flex your knee for me? Perfect. Now I'm going to rotate her foot laterally, and we're going to do the same thing with the biceps femoris. So can you flex your knee? Perfect. Now I'm going to palpate both areas while you flex your knee, and I'm going to push down for gravity resistance. Can you push up? Perfect. So now I'm going to have you lay on your side, and we're going to do it gravity eliminated. So you'll lift your leg and straighten your leg a little bit. Okay. And now I'm going to do the same thing. I'm going to palpate those areas, and I need you to flex your knee for me. Perfect. So now we're going to do muscle manual testing for knee extension. And I'm going to test your range of motion of your knee to make sure it's good. It is. So now I'm going to stabilize your pelvis here, and I'm going to palpate your quadricep muscle as you extend your knee. Now we're going to go for gravity resistance. And so I'm going to have you flex your knee a little bit, and then I'm going to push down, and you're going to push against me. Perfect. Now we're going to do gravity eliminated, so I'm going to have you sit on your side again. I'm going to lift your leg, and then we're going to do the same thing, and now I'm going to palpate the quadriceps muscle. Perfect.
One of the most common knee injuries is a sprain in the anterior cruciate ligament. The anterior cruciate ligament, or ACL, runs diagonally down the front of the knee, providing critical stability to the joint. Injuries to the ACL can be very serious and require surgery in most cases. It is one of the most common knee injuries among athletes, and according to the American Orthopedic Society for Sports Medicine, about 150,000 ACL injuries occur in the United States every year, costing an upwards of $500 million in the U.S. healthcare costs. About 70% of these ACL injuries in athletes happens through mechanisms such as pivoting, cutting, sidestepping, or out-of-control play and awkward landings happening within their sport. while about 30% of ACL injuries occur from contact with other players. Sports such as basketball, soccer, football, tennis, downhill skiing, volleyball, and gymnastics are usually the most affected by this sprain. Symptoms of an ACL injury usually include a loud pop or popping sensation within the knee, severe pain and inability to continue activity, swelling that begins within a few hours of the injury, and a loss of the range of motion of the knee. These injuries to the ACL can be broken up into 3 grade sprains. A grade 1 sprain is where the ligament is mildly damaged, being slightly stretched but is still able to help keep the knee joint stable. This usually does not require surgery. A grade 2 sprain stretches the ligament to the point where it becomes loose, thus resulting in a partial tear of the ligament. A grade 3 sprain is most commonly known as a complete tear of the ligament. The ligament has been split into then 2 pieces and the knee joint is completely unstable. While partial tears of the anterior cruciate ligament are rare, most of these ACL injuries in athletes are complete or near complete tears, and then can cause other tears in other parts of the ligament such as the MCL, PCL, or the meniscus. To diagnose an ACL injury, the doctor does a physical examination and patient history. After that, he then follows through with imaging testing such as X-rays and MRI scans. X-rays will show if there's any injury to any types of the bones within the ligament structures, while MRI scans will give a better image of the soft tissue such as the ACL within the scan. After the tests have been done, there are 2 different pathways to treat an ACL injury. There is a non-surgical treatment, but it will not heal the ACL injury. Non-surgical treatment may be helpful for patients who are elderly or have very low activity levels. However, the overall stability of the knee will be barely intact. This can be done through bracing or physical therapy. In order to gain full range of motion and to go back to daily activities, surgical treatment is necessary. However, the anterior cruciate ligament cannot just be sewn together. Instead, a tissue graft from another part of the body must be used to reconstruct the entire ligament to restore knee stability to the torn ACL. The doctor will then replace the torn ligament with the tissue graft, and the graft acts as a scaffolding for the new ligament to grow on. From there, physical therapy will have to be used in order to gain back the full range of motion and to return to everyday activities.